Good afternoon and good evening, colleagues, depending on where you're joining us from. It's my pleasure to welcome you to this webinar, which is the second webinar of the Financing Accelerator Network for NCD Regional Learning Series. Thank you so much for taking your time to join today. And before maybe you can proceed on, I will just like to notify you that we'll be recording this webinar and we'll be posting it across our network. Thank you so much. Today's session focuses on how to develop NCD investment cases, which emphasize with a clear emphasis on practical tools, methods that countries can apply in their context. My name is Victor Kidake. I'm a research and policy associate at African Institute for Development Policy. That's usually commonly referred as AFIDEP. And I will be serving as the moderator for this particular session. Thank you so much. Before we begin, maybe let me briefly talk about FUN and our mission as FUN. The Financing Accelerator Network works with government and partners in low and middle income countries, and we work to strengthen sustainable financing system for NCDs and also to contributing to progress towards SDG 3, goal number 3. The overall goal is to support countries to expand access to effective prevention, treatment, and also care for NCDs. FUN operates under three complementary functions, generally referred as the FUN model. We do have the FUN foresight, we do have the FUN forum, and we do have the FUN fund. Under the FUN foresight, we provide technical expertise and also analytical support to the countries that's within the Sub-Saharan Africa. And also under the FUN forum, we do facilitate cross-country learning and exchange, which is actually the core function where how this webinar comes in. It comes in through the FUN forum. And also under the FUN fund, we do provide catalytic seed funding to advanced priority NCD financing initiative. Together, these components support countries to move from evidence to action. This webinar is part of the broader fund learning series, which is designed to strengthen country capacity to develop robust and practical NCD investment cases that can inform policy and financing decision. Uh, in Sub-Saharan Africa, the NCD Financing Accelerator is hosted by AFIDEP, that's African Institute for Development Policy, and we work closely with country core groups within the country fund country like fund members. This initiative is implemented in partnership with the Results for Development, Access Accelerated, and the World Bank, whose technical financial support continues to strengthen countries' efforts towards sustainable NCD health financing. I would like now to officially welcome you to this webinar, which builds on foundation established in webinar 1. This was done last year, but before I can proceed on, we would like also to know who is joining us today. And at this point, I kindly invite you to introduce yourself in the chat from where you are joining us. Maybe you can just mention the country, your name, the country, organization you work for, and the role. This one will help us to understand the experts in the room and also for further exchange across countries. Let me now walk you briefly through our agenda today. Uh, our agenda will begin with a short recap of key lesson from the first webinar, which was done last year. Then we'll move into two technical presentation covering the analytical foundation of NCD investment cases, as well as how evidence such as burden of diseases, costing, return on investment can inform policy and budget decision. Then we'll move to a moderated discussion and a question and answer session, followed by key takeaway and link to webinar 3, which will be coming in the next quarter. That's around June. We encourage you, all the participants, to actively share reflection, question during this discussion segment, and also post in the chat if you have a question, so that it can be covered during that session. Uh, just jumping into our agenda item, I will do a brief recap of the first webinar. The first webinar introduced the concept of NCD investment cases and highlighted how economic evidence can support strong policy and financial decision. It also provided a shared understanding of why investment cases are important for advancing NCD financing reforms. Some of the key messages that emerged from that webinar: investment cases strengthen policy decisions by demonstrating the cost and benefit of action. And also, secondly, economic evidence supports dialogue with Ministry of Finance and also strengthens reform efforts. Thirdly, it also emerged that strong country ownership and use of local data increases credibility and uptake of findings to inform further reform. Participants in the first webinar also expressed a strong interest in understanding the technical steps involved in developing investment cases, including modeling approaches, costing methods, and how to address gaps. This was through the response they gave in the post-webinar survey, and also further engagement we have been having with the countries. And now this webinar 2 responds directly to this demand that was raised. Today's session aims to mainly strengthening understanding of the analytical foundation of NCD investment cases. And secondly, we'll introduce practical tools for costing and return on investment analysis. And also, thirdly, as the third objective, we will be promoting exchange between countries and also technical experts. By the end of this session, countries should be better prepared to develop or strengthen NCD investment cases and also support more evidence-informed financing decision. We are pleased to be joined by distinguished experts who brings extensive experience in developing and applying investment cases in different country contexts. And today we have among us Dr. Mary Nyamongo, who is the co-chair of the Kenya FAN Country Core Group, and she'll be facilitating the moderated discussion segment. And among us also we have our first technical presenter, who is Dr. Andre Zida, who is a senior research and policy analyst at African Institute for Development Policy. And he will speak on analytical foundation of NCD investment cases. We'll then hear from Dr. Gerald Mandalu, who is the head of division for public finance, financial management and the Lusaka agenda at the Africa CDC. And he will be presenting on how return on investment evidence can inform budget decisions. With that, it's my pleasure now to invite Dr. Andrew Zida, who is our first technical presenter. Welcome, Dr. Zida. Thank you.
Thank you so much, Victor, and good morning to everyone. Thanks for joining this webinar, where we'll be sharing experience in developing investment cases, NCD investment case development, with some steps and tools and practical example that we should be taken to develop investment cases. So I have full description of the process here, but for the sake of the time, some of the slides will be skipped just to make sure that you get detail whenever you want to read the slides. So why is it important to develop investment cases? There are several reasons why the investment case document has a sense among other documents like strategic plan, because it can help team to prioritize intervention that should be implemented. Also, develop a return on investment by doing some modeling across the intervention that should be implemented to understand the impact analysis on the benefits that will be gained through the service implementation. Also, there is a coherence approach to prioritize intervention and make sure that there is no fragmentation with which will help the team to align all the intervention, the resource availability, but also the plan for a long-term investment. Next. So, several critical gaps in investment case that need to be addressed. As I mentioned, the lack of prioritization during planning process, the return on investment. As you know, few strategic plan usually developed for program doesn't include impact modeling. So investment are being done, but there is no prediction in terms of gain from what we are investing. Fragmentation is an issue, and then implementation focus, which mean prioritizing intervention and focusing on intervention that will bring high impact in the implementation process. There is also the long term orientation, which mean sometimes on the implementation for action plan, strategic plans, the implementation might not be on a long-term plan, which lead to not having a way of developing a modeling, because for modeling purpose, you need to extend the period of the implementation to see high impact result on the investment being done. Next. So from fragmentation to alignment, so what is an investment case? It describes the changes as a country want to implement intervention. It's also compile case for limited number of priorities, because you need to do the team should be prioritizing the select high impact intervention, or intervention that will make sense among other intervention that's usually a country would like to implement, but for the sake of funding issue, prioritization need to be done. There's also the improvement of health benefits in the long term. Realistic plan within available resources is also a key thing to consider while developing the investment case. Next. So four essential elements that need to be included, as I mentioned earlier, it's the results as a long-term implementation process during the investment case development. You need to assess what benefit are we gaining by investing resources and implementing intervention, and how these interventions are being connected. Yes, we have NCDs intervention that are implemented, but all these NCDs intervention implementation are connected to other programs area, but also health system strengthening area, which meanwhile developing the investment case for NCD, baseline indicators implementation or coverage need to be discussed with also a regard to other program area, and also align it with health system strengthening activities to support all these activities implementation. Priority investment mean specific intervention and innovation that put the country in the trajectory of some of the goals that country have committed for. Available resources is also key to developing the investment case for NCD. Available resources mean being able to first assess what is available in terms of resources from the government, from donors, and from the private sector for the NCD intervention implementation. Knowing these resource availability will help the team to focus on priority intervention and impact analysis, which also means Once you have the resource availability, assess the resource availability, and you develop your intervention that should be implemented, there is also room for gap, funding gap for negotiation to be able to cover the gap. 2 or 3 years later, if you see that there is no resources to cover the gap, it's good to adjust these framework and the investment case budgeting to make sure that at the monitoring and evaluation process, we are aligned with something that we committed to do with available resources. Otherwise, the evaluation might not be in a good line with what has been planned because of the lack of resource planning. Next. So priority investment mean choosing impacts or intervention that will bring value in the implementation process, not selecting all the intervention that people would like to implement, but for the sake of resources, there is a need to invest on activities that will bring high impact by selecting how resources will be delivered, who will be implementing all these intervention, and the geographic area need also to be balanced in the planning and also the investment case development process during the intervention selection. So here we are using maternal and child health for intervention as an example for a focus on some of the antenatal care intervention, and then the delivery methods by selecting some of the delivery channels, primary healthcare level, hospital level, or at the central level for the management and health system strengthening process. The target audience for all these activities implementation, and also the geographic area to achieve all these interventions. Next. So resource should match our priorities because as the fundamental principle for investment case development is to adjust resource availability with what we would like to implement in terms of activity implementation. So the investment case should not present large resource gap. Instead, we should prioritize activity implementation to match with what resource availability, but also have a room for negotiation in terms of gap for additional budget negotiation. So that's why in terms of, come back. In terms of costing process for this intervention, building scenarios are really key to developing the investment case. Scenario one could be, for instance, matching the resource availability with intervention implementation. Scenario number two could be increasing the coverage, but also playing with intervention that need to be implemented in terms of activities implementation. We can build 2 to 3 scenarios and then compare for each of these scenarios in terms of modeling what are the benefits that we are gaining in terms of scenario implementation, because each scenario will be tied to coverage in terms of intervention implementation, and each coverage tied to the resource availability will also bring benefits. So at the end of the process, comparing this scenario in terms of budget requirement, but also in terms of benefits, will help the team for budget negotiation with key actors in the country for resource mobilization. Next. So the step for developing the investment case is first build on existing work. We don't just go and select the intervention. Sometimes there is a strategic plan available in the country. There is budget lines available in the country. There are platforms. There are also activities and plan for mid-term or long-term implementation. We build on existing work, selecting the intervention, and also learning from indicator baseline coverage and target coverage from stakeholder needs, but also being able to adjust. So key deliverable are also essential for these developing the investment case, because the quality insurance approach, the clarity in links with health financing platforms, stakeholders needs, but also the way these interventions should be implemented are key to understand before targeting all these deliverables and making sure that there is a track of all these activities implementation across the year. Next. So the situation analysis, as I was saying, on the will give you a comprehensive understanding of the coverage, which means assessing what have been implemented in the past year will help you understand what are the priority, what are the key interventions that need to be selected, what are the geographic area that need to be included in the process, depending also on the poverty area, the resource availability, the knowledge on the area, but also, as I mentioned, the coverage in terms of intervention implementation will give you the baseline indicators, age, and also the group of population in need and the socioeconomic status of the population in the region will help you target the intervention to that specific area, and then come up with some of the results that need to be achieved by committed goal for in the country. So I'll pass these slides and the next one too. Go ahead. Yes. So as I mentioned, costing and the resource mapping is key to developing the investment case, because selecting the intervention are key, but also knowing how much this intervention will cost, and modeling the projection of this intervention across several years will help you understand the resource needed and the resource availability. Usually, the goal of costing is a clear understanding of the detail and approach. By doing the costing, also, you define how these activities will be implemented in a country. Depending on the country, the implementation might be different from how countries are usually implementing them, and key actors that are implementing the activities. So that's why the costing cannot be transferred from another country to another one, because there is a discussion that need to be done on prioritization of the intervention that will be implemented. So maximizing the return on investment are key also, by modeling the impact of all these intervention implementation. Linking them with resource availability will help you to understand the return on investment and help you on the budget negotiation for resource mobilization, which are something usually that's being asked by, for instance, Minister of Finance, from where we are going to mobilize resources. And some of the key questions are: if we give you the resource, what are you going to provide in terms of changes in the mechanism? What are we gaining from this implementation? So if there is no implementation, we cannot target the return on investment on life save, on the mortality reduction, and yes, all those key activities that will be implemented. Next. The monitoring and evaluation is also key on developing an investment case, because without a proper plan to track what we are implementing and what we are getting from what has been planned during the investment case, will not give you a clear view of what you are implementing and how you can report back to budget negotiation, but also to reframing the activities implementation in a way that we will be able to achieve great results. In many countries, we have different platforms for tracking activities implementation, which sometimes are well aligned with some intervention like maternal and child health, HIV, TB intervention. They are well defined, But when it comes to NCD, indicators are not really properly aligned in some of the platform like the DHIS2, the survey or the SARA survey that are being developed. We don't properly track NCD intervention, which is something that need to be well discussed during developing the investment case. Will also be an opportunity to include all these indicators that need to be tracked in the DHIS platform, for instance, or all these survey work that will be conducted. Next. So here the financing repartition on activities implementation are key. Donors, private sector, government funds, what are they investing for? Where are they implementing these activities, resources? Which activity to be tied to which fund? As we develop the investment case, when you do the budgeting, the costing, the mapping on the costing should be mapped with resource availability by source of funding to help you understand which activity are being supported by which partner. For instance, government resources are usually funded and used to pay salaries, for instance. It's something that we can track. And we, during the costing and the budget mapping process, we usually minimize the government contribution because we don't map properly what the government resources are being tied for. Salaries are a big component in terms of supporting NCD activities implementation, but we lack tracking all these investment from the government. We also have health system strengthening by proper investment on infrastructures, logistics, and all those components are not usually properly tied to government fund, which is usually a gap on the resource availability and government contribution to NCDs. So that's why the mapping is really important. Donors' resources are usually well mapped to implementation activities. Private sectors on NCDs also understanding what are private sector contribution to investment on NCD activity implementation, but also household spending on some of the out-of-pocket payment for NCDs activities need to be tracked to help understand who is paying for what, and by understanding the source of funding for each activities, it will help reframing the implementation process, but also help cover how household out of pocket could be reduced as we are implementing the activity, but also help promote good implementation by tracking properly activity implementation and the source of funding. So from planning to impacts, as I mentioned earlier, investment case represent a fundamental shift to how countries approach intervention financing and planning. It will also help countries to achieve a sustainable development goal. And then an investment case identify priorities, justify investment, resource mobilization, and external donors' contribution to activities implementation. So there is a tool out there to support costing. Can you go? Yes, to support costing. And one of the strongest tool that we have out there to support investment case development is the tool called the OneHealth. The name has been changed. We are still developing an online platform called integrative tool for planning and costing. The OneHealth tool is a tool available online. It's free for use. There is no need to, it's just having the link and then download the tool. There is a desktop version and also an online version that we are still working on. The tool, why this tool is important, because it's combined program intervention implementation, health system activities such as investment, logistics, salaries, and all those components related to health system investment. But also the third component that are being combined here is also the modeling modules, which has a strong modeling module for NCD intervention. But on top of that, those three components for NCDs, the One Health tool also have a look to other intervention, because the NCD intervention are not being implemented as a standalone in the health system. There are interconnection of NCD implementation with other intervention on the HIV, on maternal and child health activities, which sometimes play to increase the impact of NCD intervention implementation. So that's why the One Health tool is one of the strongest tool in the system to support NCD investment case development. Next. So the core capacity for the One Health tool, as I mentioned, it's the intervention, costing, the impact analysis, and the NCD module that has been incorporated. Next. So that's what we have to share with you in terms of process and tool available to support the NCD investment case development. We are available if there is any question on that. Thank you.
Thank you so much, Dr. Zida, for that very clear overview of the analytical foundations which are underpinning the NCD investment cases. Key things I've picked. First, developing an investment case requires a strong analytical base. And also, this includes understanding the burden of the diseases, identify cost-effective intervention, and also estimating the potential health and economic impacts. However, generating evidence is one part of the process. An equally important step is also ensuring this evidence is presented in a way that it communicates with the decision makers, particularly the Ministry of Finance, who must balance multiple competing priorities, maybe focusing on other diseases within the same limited fiscal space. Given that, we can now move to our second presentation, which focuses on how analytical evidence such as the burden of disease, costing, return on investment can be interpreted and applied to inform budget decisions, particularly within the Ministry of Finance. At this point, I would like to invite Dr. Gerald to take us through this important perspective, linking analysis to the final decision making. The floor is yours, Dr. Gerald. Over to you.
Thanks so much, Victor. And next slide, please. Yeah, so I just have to say that I work for the Africa CDC, but I draw most of what I'm going to speak here from my previous role as Director of Planning and Policy in the Ministry of Health in Malawi for the past few years. So I think my key argument here is that translating the investment case from what it is into the budget must start with aligning it from the outset with the budget structure, understanding what is feasible and what is not feasible from the budget point of view. And as a result of that, and given the situation where we're in now, we are mostly looking at the government budget as being the core, because domestic donor funding has reduced, and maybe other financing in many countries isn't also very predictable, or maybe isn't fully aligned to the government budget. So how do we do the planning when you're focusing on that government budget? So I'm looking at how do you look at burden of disease, which mostly looks at the health intervention versus risk factors of the diseases. How do you look at the level of the way you aggregate the burden of disease and what impact it has on your planning approach? And then I talk about the implications for planning and budgeting, and a little bit on making a shift from verticalized to platform-based thinking and approaches. So in terms of aligning with the budget structure from the outset, what I'm thinking is, since we have countries on the call, you know that the Ministry of Finance is mostly making allocations to sectors or ministries or departments or agencies, and yes, it makes budget ceilings to those sectors. In some cases, Ministry of Finance make ceiling allocations to clusters of ministries or thematic areas other than just one ministry. And we also know that in most cases, ministries or countries are implementing program-based or output-based budgeting, which means you're focusing on high-level results for a specific program other than focusing on fragmented programmatic results. The other issue also that must be considered is the extent of fiscal devolution. What decision-making power does do sub-national level governments have, and what discretion do they have over planning and budgeting as well? So that's another consideration. And then we also have the planning and budgeting cycles for donors. We know that in some cases, countries have to make grants for certain donors that span a few years. And what's the implication of that in terms of the fiscal space available to implement the investment case? And then even purchasing mechanisms as well. How does the government purchase services, or how do other partners purchase services? So I argue that translating investment cases into budgets, as I said at the beginning, starts at the investment case planning. And my argument also is when you're looking at the government budget, especially for non-communicable diseases, you have to be looking at what proportion of the whole government budget do you maximize? What is feasible to maximize? Because looking at health, just the health budget, when you're approaching NCDs, I feel like we still end up in the same cycle of thinking about Abuja targets that have been stagnant for years. But how do we shift from just looking at the health budget for NCDs and looking at how do we maximize the whole of the government budget? So also, practically from my experience, I know that Ministry of Finance in some situations use return on investment evidence, and it's ideal to do that. But we also understand the limitations that are there, that just in the health sector, the interventions that are there, we don't have return on investment data for all of the interventions, let alone other sectors. But we also know that where we have the return on investment information in the health sector, that's only focused on evidence in the health sector. That sometimes overlooks what cost-effective interventions are in other sectors. And it's also important to note that Ministry of Finance, as Victor alluded to, are faced with pressing issues in balancing the fiscals. Allocations to other sectors, they have to look at debt servicing, increasing demands on the budget. All of those things come into play. And mostly, although they appreciate the evidence that you give them, it is really them trying to be as pragmatic as possible. And that's why I come again to the argument that maximizing opportunities in the budget structure in this tight environment is very key to translating the investment case to budget reality. So as I say, the first point to tackle is burden of disease, say in most cases, disability adjusted life years, which are really morbidity and mortality. And then taking a focus on not just burden of disease, but also the risk factors that cause the burden. So which encourages focus on challenges outside the health sector. So the point here is, if you're going to take a whole of government approach, utilize government allocations to other sectors for the benefit of addressing NCD burden, then you have to take this approach from the outset. If we look at the next slide, you see that I'm just using a Malawi example here. We are ranking burden of disease by conditions. We usually, when you're actually dividing your package of interventions, you're looking at this and looking at what interventions are available in the health sector to address this burden. So, for example, in the case of Malawi, you have maternal and neonatal disorders at number 1 and then descending like that. But you also have quite a few NCD conditions, dispersed across this list. So if we go to the next slide, you see now we switch the approach to looking at risk factors. And these are mostly issues that are not in the health sector, but they're responsible for most of the NCD burden. So how do you combine the burden of disease plus the risk factor evidence so that your investment case from the outset already looks at utilizing resources that are not just in the health sector? If we go to the next slide, the other point that I was making is the level of aggregation of NCDs. We know that in many contexts, I'm citing Malawi example here. Overall, you see that NCDs contribute to 34% of the burden of disease, which is really huge. And we know that low-income countries are on an epidemiological transition. But when you look at the individual conditions, it's really low percentages. So you look at cardiovascular disease, which is 5.54%, much lower than, say, maternal and neonatal disorders, which is at 12%. And all of that, you see all the ones that I've highlighted in green. So there is also a point here. If you are going to think about individual interventions and then trying to plan on the basis of that, maybe that's a problem. But how do you think about NCDs as a totality, the 34%, and how you're going to do to respond to them in your investment case? Next slide. Here, I'm then just looking at the level of aggregation and prioritization of interventions. It's maybe a little bit technical, but I would just say that on the left, what you see on the left side is we have a ranking of burden of disease, as we did in the previous slide. And then we make a cutoff at D. Everything we are prioritizing A, B, C because those are the conditions that are really imposing the highest burden on the country. But then that's got a problem because you're going to omit conditions like F, which in this case, for example, could be one of the NCD conditions that impose a low burden of disease. But when you think of them in totality, it's a big, we are back to the 34%. On the right side, we are looking at, if you look at the top cause of disease burden ABC, then you may end up in a situation where you are omitting interventions E and F, which are really very cost-effective interventions based on some maybe cost-effectiveness threshold, very effective interventions, but because you already omitted the burden for the smaller kind of NCD conditions, then you also lose out on this. So you see that at the end, when you're really planning this, when you're looking at individual versus aggregated, you maybe not maximizing the value of your budget. In other words, you're omitting some cost-effective interventions that really have added value to the objective of addressing NCDs. And next slide. What are the implications of these points? The first one and the second I just made. So integrated thinking is very important, making sure that there's a client-centeredness, because that then takes you away from this issue of having to have a threshold of burden of disease to which may omit some conditions which individuals may present with when they come to the facility. So shifting to integrated or platform approaches, intersectoral collaboration, moving away from sectoral planning and budgeting. I know this is happening in some countries, but how do we, if you have looked at those risk factors, and you know that most of those are not in the health sector, how do you move from just budgeting on your own, but thinking together with other ministries or sectors to determine joint priorities? And also there's a concept on intersectoral co-financing, which has been there for the past few years, but it hasn't quite gained a lot of traction. This is also to say, if we have developed joint priorities, how do we co-finance them as sectors? So when you receive your budget ceiling as a Minister of Health, how are you using that with, say, the Minister of Agriculture or the Minister responsible for nutrition or social welfare to really draft joint priorities that are going to address, or that are going to actually address your investment case? Of course, there are challenges in terms of how do we measure joint, how do we measure, benefits and things like that. But I know there are always pragmatic approaches on how sectors that are working together can measure joint costs as well as joint benefits without really, maybe using all these sophisticated methods. Next slide. So going forward with these integrated approaches, so really thinking from, okay, we've got this, we've got all these different conditions, but how do we flip that to thinking about, okay, we want to have a preventive function in the health facility, screening function, diagnosis, and patient support, which are really the things that have existed, but because of like verticalization that has been passed on to us in many situations, we haven't been structured, we haven't been planning in this way. Next slide. Yeah, so if you go on and on. Yeah, so it's the same, it's pretty much emphasizing the same principle that you think from a patient, from a shift from a disease continuum to a patient continuum approach. So thinking of, okay, if we have this population, what are the biggest cause of the disease pain we are seeing? And we want to make sure that we target those conditions when we're screening throughout the whole process, consultation, diagnosis, treatment, so that you shift from really thinking about this programmatic condition, but really think about the client and how you're going to screen for the things that may be prevalent in their population. And then also, finally, maybe I'll make the point about making that shift also means where it's contextually appropriate. I know that in some cases this works, some it may not work, but the way the government budget is structured is such that government is paying for the overheads of the facilities, mostly the inputs and overheads of the facilities. So in some contexts, there's thinking about structuring from costing like individual interventions to looking at if the facility is going to provide this package that we have specified in the investment case. What kind of overheads do they need? We know that some services may need differentiation. How do we take care of that? And what will be the the cost of this differentiated care? So making that shift will also help to cement this integrated approach. And I think that should be okay. Finally, yeah, I'm also just making that the final point that moving away from verticalized to platform-based thinking and approaches aligns with how budgets are usually structured in ministries. I'm just giving an illustration of you've got your vote, you've got your cost center, you've got your program, your sub-program, chart of accounts, and the new allocation. This is how a standard budget for a government will look like. And it's very important to make sure that when we are thinking of translating the investment case to the national budget framework, we're already thinking this way. Thank you. I think that should be my last slide. Thank you very much.
Thank you so much, Dr. Gerald, for such an insightful and highly practical presentation. We have had an important perspective on analytical foundations of NCD investment cases, as well as how we can use this evidence, such as the burden of diseases, and how to interpret and use to inform policy and budget decision. We'll now move to our second last session. That's the moderated country discussion and question and answer session. I know you have prepared your questions. We'll be raising them in this next session, and also if you can be able to post it in the chat, will be addressed in this session. I will now hand over the session to Dr. Mary Nyamongo, who will facilitate the moderated discussion session to try and bring in country reflection and also the question and answer. Over to you, Dr. Mary.
Thank you very much. And to the two Daktaris, thank you for really challenging us in terms of what is needed to have a robust investment case. Due to time constraints, I want to welcome our three speakers. We have Kenya, Ghana, and Somalia. You each have 5 minutes so that we can also allow our members to make some comments. So Kenya, Dr. Njuguna, would you want to go ahead and share what the experience of Kenya has been on the investment issues? Over to you, Dr. Njuguna.
Dr. Njuguna, you should now be able to speak.
Dr. Njuguna, your 30 seconds is gone. Please come on.
Dr. Njuguna, you should be able to speak
Yeah,
now.
so thank you very much, Chair of the session. Dr. David Njuguna is my name. I work for an organization called Futures Health Economics and Metrics, and part with the Center for Epidemiological Modeling Analysis, and part with the Savannah Global Health Institute. I've been part of NCD modeling for Kenya for quite some time when I used to work at Ministry of Health Planning. But of course, reflecting on the discussions that have gone around, one reflections on the readiness for the country. So we see a situation where Kenya has both the policy and the strategy framework, including having Kenya Health policy and even succinct NCD strategy that highlights what are the issues that we need to look at. And of course, at higher level, good political goodwill. We have a dedicated NCDI Poverty Commission, if I could call it so. Then, of course, looking at the economic base. So this is a country that is spending about $850 million on NCDs. That's as late as 2023 data. And of course, looking at where the burden is here, you find that 26% of this is actually coming to from household, meaning then we should see how we emphasize really the investing in the interventions. And of course, looking at how we have set the pace in investment. So we find different levels for data-driven, calling for a data-driven reprogramming at both the national level and the county level. There are quite a number of opportunities that we could look at to ensure that one, we leverage on existing mechanisms, be it the primary healthcare fund, of course, the discussion again around integration, as well as thinking about how do we also engage private players into this, looking at the financing as well as the fiscal space within the country. Of course, looking at capacity, yes, within the country, we have both the technical and institutional capacity to generate an investment case, where, as mentioned even by the speakers, they from national planning and treasury level, where there is even public investment management that actually looks at viability of investments within the country. So the owners are actually within the sector to speak to these organizations so that we have targeted budgets. Of course, other institutions. So we have Kenya Institute for Public Policy Research. We have the Kenya National Bureau of Statistics that have actually been very essential in modeling for demographic and health data. We have the universities, and also within the Ministry of Health, where there is a substantial capacity for these investment case. We did quite a lot of costing data so that we see the needs. Of course, applying some of the tools like OneHealth so that we look at the impact modules within this that could actually show the level of investments as well as the returns that could actually come along. In terms of the data sources that we have, so we have both the financial and epi data, be it from the demographic health surveys. We have also from Ministry of Health reports that talks about the epi side, and of course from the finance side, we have a robust national health accounts that looks at how much the country is spending. And of course, using the Kenya National Bureau of Statistics data to model the productivity losses in the account of morbidities and mortalities. And maybe lastly that I could talk to is now some of the challenges that we also have within this. One, looking at that big burden borne by the community on account of NCDs. So we find a situation where 28% of households are pushed to poverty on account of NCDs. So that means there is really great importance to invest in NCDs. And of course, looking at how we've been financing. So out of the $850 million spent on NCD, you find that government's contribution is actually around 2 to 3%. Whereas if you look at it as a percentage of GDP, we are talking of a number like 0.7%, which is really a mega investments. So I think I would pause there. Then I could pick up later if there are issues that needs to be addressed. Over.
Thank you very much, Dr. Njuguna. Maybe a reflection as we go to the next speaker is, are we capturing investments in other sectors? For instance, education, sports, and other investments that would make a difference to the activities, to the investments we are talking about. So something to think about in your next response. I want to welcome Labra Musa, who will speak 5 minutes about what's happening in Ghana. Over to you, Labra.
Yes, thank you very much, Mary, and greetings to my co-panelists and the speakers, and also to AFIDEP for putting this important conversation across. Yes, so let me begin by saying that I don't think I'm in the capacity to speak on your reflections whether other sectors are doing investment cases. Maybe my next speaker could take that, but let me say that yes, in fact, in Ghana we've had some examples of investment cases, but what I can speak on specifically is the tobacco one that we did. So the UNDP and then also the WHO Framework Convention Tobacco Control Secretariat assisted Ghana to develop an investment case for tobacco control, and why we need to invest in putting measures to ensure that we are able to implement provisions to reduce the burden of tobacco and largely on non-communicable diseases. And currently, Ghana is also working on a mental health investment cases, again, being led by the NDPC with support from the Ministry of Health and other agencies, and also civil society organizations. Let me mention that I'm really, really happy about this conversation. And like my colleague from Kenya mentioned, yes, in terms of capacity to do these things, they may exist. But again, if country level is able to get, this kind of, training or capacity, as presented by the two earlier speakers, the first speaker, it will go a long way to, to put countries in a better position to develop investment cases that are fit for purpose. The challenge probably for me is that non-communicable disease is broad, and so then you need to unpack them. So for instance, you can I'm not sure if you can do a very broad and holistic investment case on non-communicable diseases, because we have the risk factors, we also have the the disease itself. So I think that if we can position ourselves to be having it, maybe an investment case on each of the disease burdens, especially the most pronounced one, like diabetes and the need for investment in that area, like hypertension, and probably on other chronic conditions. And then also looking at the risk factors, separately, just so we're able to, to get government to also invest in the area of, health promotion, because that's one area that I think that is lacking a lot of dedication in terms of budget allocation for them, especially in our part of the world where you practically will see that investment goes mostly into, areas around, investing into spending on, the disease when people eventually get it. But you hardly will see a very dedicated rollout plan, dedicated for health promotion throughout the year, which means that people will continue to get the disease, but government is ready to invest, adequately to support their treatment, which, does not augur well. So, but having said this, I think when it comes to issue of modeling, I think that many countries have done very well. And let me say that many government interventions mostly are based on modeling. Because, for instance, when Ghana did the modeling the modeling on tobacco and also excise taxes, for instance, it helped the government to understand to what extent, would government benefit if it, it increases taxes on healthy commodities? What are the benefits in terms of public health? What are the benefits in terms of revenue? And then also, like I mentioned, government have been using this modeling, in many instances to advance argument for public health. But when it comes to investment case, I think that's where we are lacking. We need to invest adequately in that. So like I mentioned, for instance, if you come to Ghana, for instance, the investment case that I mentioned, for instance, it is mostly driven by development partners. And I think that's an area that we need to look at quickly. Otherwise, it may look like there's not much commitment and investment into the area of development of investment cases, which I would say that, yes, when it comes to my part of the world, like Ghana, it seems like that is the case. But of course, it's also because of probably lack of understanding of what investment cases are and what they seek to do. So, the path that AFIDEP have taken, I think, is the way to go. And if you're able to scale this up and then target countries like Ghana, Malawi, Kenya, to get policymakers to understand, the context, and then pick the disease condition one after the other, I think that would go a long way to help us. So,
Thank you.
I'll end here, Mary. But let me just say that I will have a question for the first speaker. Maybe he want to clarify if he has seen anywhere in the world where we've got a broader investment case for NCD and not specific, disease condition. Thank you, and over.
Thank you so much, Labram. I think you bring in an important issue around health promotion and whether we really are investing in it rather than just looking at the curative aspects. It's a question, I think, for all the countries, even as we undertake the investment cases. I would like to welcome Omar Abdullah from Somalia. 5 minutes so that we can allow some questions. Over to you, Omar.
Thank you, Chair. Thank you, Dr. Mary Nyango. And my name is Omar Abdullah Omar. And just from Somali perspective, is non-communicable disease are no longer only a health issue. They represent a growing economic and fiscal risk. National data show that 26.3% of the adults having hypertension and 21.1% having diabetes, affecting large share of economically productive population. This translates into reduced productivity, increased dependence, and long-term pressure on economic growth and human capital. At the same time, our system is not responding efficiently. So the NCD health facility assessment or harmonized health facility assessment of 2023 data shows that only 29% of the facilities provide basic NCD services, just 3% with a primary health care and diagnosing and treatment of the major common NCD cases. So from a cost-effective perspective, is managing hypertension at a primary care level cost less than 50 to 100 US dollar per patient per year, whereas complications such as stroke or heart disease can cost hundreds to thousands of dollars per case. This means that early investment in prevention in primary care can reduce downstream treatment costs by several multiples. Also, another study, which is national integrated household budget survey, indicates that households are already absorbing these inefficiencies. Nearly 48.5% of our people do not seek, care due to the affordability and where most of out-of-pocket lies there, and in economic vulnerability. And also global evidence shows that every $1 US invested in a core package of NCD intervention can generate at least $7 US in economic return. For Somalia, even modest investment in hypertension and diabetic control could yield a multiple-fold this return while reducing long-term fiscal pressures. However, the key constraint is not only financing, it's also data and system limitations. Somalia faces important data gaps, limited national burdens with no recent stepwise survey, incomplete mortality and risk factor data. According to the NCD portal globally, it shows that NCD mortality in Somalia, over 800 more deaths comparing to the maternal mortality, which is about 568 per 100 live birth. And also weak routine systems with NCD indicators not fully integrated into the DHIS2, and inefficient economic data, including limited costing, expenditure tracking, and return of investment analysis. And finally, a limited disaggregation to assess equity and regional disparities. These gaps contribute to the broader system challenges, including difficulties translating fragmented data into policy-ready investment case, limited engagement with the Ministry of Finance with NCD not yet framed as an economic priority. So capacity constraints in health economic and investment case development, competing priorities, particularly communicable diseases and humanitarian needs, and fragmented partner support, limiting alignment around a unified national investment frameworks. Despite these challenges, there is a promising opportunity. Somalia is advancing towards universal health coverage with a strong focus on primary health care and system strengthening, which provides cost-effective platforms for NCD investment. Additionally, through these efforts, Somalia is currently in advanced stage of development, costed NCD multi-sectoral strategic and policy, which is engaging on multi-sector government sectors, including the Ministry of Education, Ministry of Health, Ministry of Agriculture, Sports, Finance and Commerce, and so forth, which is very important. Again, also there is advanced, progress in expanding the NCD monitoring indicators, which we are now integrating to DHIS2, as well as electronic medical record, case-based, which is very essential for ensuring NCD and continuum of care and follow-up and referrals between facilities. So, and also the country is adopting BEN, WHO, and best advice and intervention into primary health care. Over 1,200 health facilities in the country. 83% are providing primary health care services. That's where we can leverage implementing BEN, which is among the best intervention or best advice of the WHO or globally recommended that can reach and impact an economic return and at the primary healthcare level, as well as
Omar, please conclude.
Okay. So finally, moving forward, Somalia's priority is to develop a national NCD case investment, the cost of inaction also, the return on investment, and the pathway for sustainable domestic financing. So that's where we are heading now. And thank you so much. Over to you, Mary.
Thank you so much, Omar. I think, again, all of you are talking about data, and you bring up an important issue on disaggregated data, and also just recognizing the regional differences. So as we talk about investment, that's important for us to also bear in mind. We have Dennis. Dennis, I will have you for a few minutes. Dennis from Uganda. Please share one experience of what's going on in that country.
Sorry,
Dennis,
Dr. Nyambo is not in the meeting.
Not in the meeting. Thank you very much. Then I will allow, I'll open it to members who are still here to ask questions. Please indicate who the question is to. And as you do that, maybe Zida, you had a question regarding whether there is, you've ever seen an overall NCD investment case instead of specific specific condition investment cases. Over to you. Could you please answer that? Or is that Dr. Mwantalu? There was a question to that effect. Zide, have you seen any?
No, NCD investment case in a way that include impact modeling and budget projection, not yet. I haven't seen it. The most of the investment case that we use to develop are around communicable disease, and that's why this is an opportunity to also learn from. Indeed, the investment case, the NCD impact modeling, for example, which is one key component, is a module that has been added in the OneHealth tool not long time ago. It was there at the start of the building of the tool, but it was not perfect. And the team was working on it. And it's recent years that many of these modules have been concluded and then well aligned with the intervention.
Okay. Thank you very much. Any comment from members? We'll take one or two comments, and then I'll pass it on to Victor. Anybody raise your hand if you have a question, a comment? I cannot see in the question and answer, there is no question. Do we have any comment for our facilitators, our presenters? If we don't have a comment, I had a, okay. Abdullahi. Abdullahi, go ahead.
Abdullahi, you have the mic. Carry on.
Am I audible?
Yes, you are audible, Abdullahi.
Yes, thanks. Thank you very much, colleagues who have presented this important presentation and the representative from various countries for their insightful comment. I will be very brief. I have three questions, and my questions goes to the second presenter. I think it was Zida, right?
Zida was the first one. The next one was Dr. Mandalu.
Yes, exactly. The one presenting the tool about the OneHealth tool. Yeah.
Yes, go ahead.
Yes, thank you. Since the OneHealth tool integrates multiple WHO guidance documents into one framework, how does it help prevent siloed budgeting between different programs? For example, like NCDs and HIV or even tuberculosis. That is the first question. The second question is how this tool been used specifically to support financing advocacy for primary health care, and does this tool allow for modeling of a shared cost, like for health workers and infrastructure across these different disease programs? The third question is, I hope you are jotting down my questions.
Yes.
Yes. The third question is beyond just costing, and which specific, for example, which specific health impacts and are currently being implemented for NCDs investment cases. I mean.
Okay, thank you, Abdullahi. We'll take another comment. So, Zida, you have 3 questions. Think through those. Any other question before I hand over to Zida and the other panel members? I cannot see the hands, so if we don't have, then we'll move on. Joseph Morgan from WHO has talked about a Lancet review, showed a list of 21 members. Can Joseph speak? Can we allow him to ask the question? Joseph, Dr. Morgan?
Yes, thank you very much. My question is similar to actually what a colleague from Ghana had asked earlier, and also what the gentleman from Malawi, from CDC presented. Analysis of single NCDs might not really give us a bigger picture of what needs to be done. And I came across this Lancet article of 2023 that explicitly provided list of 21 interventions that if countries could implement, then they would achieve SDG 3.4 by 2030, particularly low and middle income countries, including African countries. So I'm wondering whether really there is that line of thinking to do a pool.
I've lost Dr. Moga. Can somebody hear Dr. Moga?
No.
Okay. Zida, we don't have too much time. Maybe could you start to answer the questions, and then I'll give Dr. Manthalu some time.
Yes.
Respond to some of the questions.
Okay. Thank you so much for the interest. And on the question related to how the tool is being used to for primary healthcare intervention costing and modeling, as you know, primary healthcare intervention are, I would say, transversal intervention, which some of the intervention could be in various programs in the such as maternal and child health, HIV, and many other program intervention. But yet, if the focus is on primary healthcare intervention, there is an option for you to be able to select all the list of intervention that you would like to include in your costing and modeling process, but by creating a separate program in the software that you will name primary healthcare intervention that you want to cost, and then you move all the intervention from all the program area to that specific module. Then you start doing your modeling, your costing, and all the projection. There are preloaded intervention and treatment guidelines included in the tool that you can use. But I will really advise working with program specialists to review all these treatment guideline that has been included in the tool, because based on the country implementation guidelines, it might change a lot, and also all the unit costs need to be adapted based on the country unit cost, and also the intervention implementation process. The modeling is the same. It's once you have the baseline data indicators, and then you have the projected indicators, you build your scenarios, and then there is a way for you to generate the impact based on a specific intervention that has impact, because not all interventions are linked to impact. And then after that, you can now do your side-by-side comparison on modeling what are the gain from budget that has been planned to be injected as compared to increased budget, and then you build all your scenarios. So the question related to the side costing on various program, yes, that's if you want to do the costing with the tool using a strategic plan that includes all the programs in the country, in the health system, then you have the OneHealth tool that can include all the programs, up to 56 programs that you can include. And you do the costing, HIV, malaria, TB, all of them together will talk to each other and combine them. But then if you only want to focus on NCD intervention costing, then you will isolate all the NCD program intervention, and then you do the costing for that specific intervention. And then the result will be a standalone result, and you have your result that you can generate. The third question was not clear beyond the costing on health impact. I didn't get it very well.
Okay, because of time, maybe let's allow Dr. Mandalu to respond to some of our question, and then I hand over to Victor.
Thanks so much, moderator. I'm going to say that the question that Dr. Morgan was he asked, I think that's what I want to comment on. I really think the onus is on countries. Because defining a package of interventions either through an investment case or through an existing NCD strategy is one thing, but the way you implement it is another. So the second part is really redesigning your, in this case, we'd say maybe primary healthcare processes, either the community or so, for example, if you're doing community outreaches, how do you rethink that so that when you do an outreach clinic, it's an integrated clinic within the constraints of your finances? Not everybody is going to have the same package, but within your constraints, what are you able to take the communities? If you're at the health center, how are you able to rethink? Because now, because of the legacy systems, we always think of the systems are already designed in silos. The people come to an NCD clinic, sometimes is even separate from an HIV clinic. But there was a slide where I was showing, think of when the client comes, what do we want to screen them for? From there, where, do they go if they need diagnosis, treatment, and things like that? So rethinking the whole approach to this, I think, is the way, because like doing this, all this prioritization and everything is just the first step, but the harder part is really how do you redesign your system to deliver that package in a way that focus on the client and takes the opportunity that the client is there to also look for all these other NCD conditions that you have already.
Oh, thank you very much. Just because of time, we will not be able to take in any more comments. Let's wrap up. Over to you, Victor. Thank you, speakers. Thank you, the country representatives, for sharing your experience. I think we need to really learn from countries and providing an opportunity for you to tell us where you are moving to and what you're doing, what challenges you're experiencing. We'll be able to build on investment cases. Over to you, Victor. Thank you very much.
Thank you so much to you also, Dr. Mary, for facilitating that session quite well, and also for assisting in bringing out the key insights. At this point, I will now like to invite my colleague Luana to provide some key takeaways from today's session, as well as providing us for the next steps. Over to you, Luana. Thank you.
Yeah, thank you, the moderator. So the webinar has explored why investment cases matter and how they can be used to influence policy decisions on NCD financing. The experiences shared by Kenya, Somalia, and Ghana have highlighted what data is available on NCD, exposed data gaps, and provided clear direction on what the countries can do to develop NCD investment cases. So to keep these conversations going, we are going to conduct our third webinar in June, and the title of the webinar will be determined based on your feedback, which you can provide through the evaluation questions that will pop up at the end of this webinar. We encourage you to take the survey as soon as it pops up on your screen. We are also organizing a cross-country learning workshop this coming August, which we hope you will be part of. Finally, we would like to request your participation in the following upcoming global events. So we have DevEx Impact House, the DevEx Impact House Capital Summit on the on the sidelines of the World Bank Spring Meeting, which will take place from 15th to 16th April 2026. This would require registration, and we also have the World Health Summit Regional Meeting, which will take place from 27th to 29th April 2026. This also requires registration, and we have a fun event on the sidelines of the 79th World Health Assembly, which will take place on 19th May 2026 in Geneva, Switzerland. This will be participation will be by invitation only. And then we also have annual member meetings of the Coalition of Access to NCD Medicines and Products, which will take place on 13th June to 2nd July 2026 in Nairobi, Kenya. This will also require your registration. And then there's also a website there where we have all the materials that are on NCD. If you're looking for anything related to NCD, you can access that link. So just to mention that all the presentations that have been made here, they will be sent to each one of us that have participated in this webinar. Finally, I would like to thank you all for your time and also contributions as we look forward to further engagements.